Good.
So my name's Tim. Some of you may remember me. About 18 months ago I did a talk when I was still engaging people to take part in some of my PhD workshops. So my PhD question is, could smart communities improve the efficiency of cancer services in Sheffield? And what I mean by a smart community is what I put up here, which is human and non-human agents collaborating with the stated aim or intention of significant positive change. I'll talk in a bit about how I got to that definition, and I've done this little diagram up here. So ultimately, what I mean by that is so an example of a non-human agent is artificial intelligence. Babylon Health is, and IBM Watson are examples of artificial intelligence, and on the human side, we're talking about patients and healthcare professionals and managers and so on. So from a citizen engagement side of things, I'm primarily talking about patients and ex-patients, so cancer survivors and so on in terms of this. So why am I relevant to talk about this kind of stuff? There's a few things here, actually something I haven't put up here, which I perhaps should have done, linking back to the talk about playable cities and stuff, is as well as what I put up here, I'm also from an arts background, for about almost 15 years actually. But academically, my background is urban planning, sociology and business, the second two of those both at postgraduate level prior to my PhD. I've been a community health manager and a cancer survivor. This actually isn't me, but I've been there. So in terms of, sorry, am I moving around too much?
No, you're right in the middle, Tim. Choose where you're going to stand.
All right, I'll come over here. Sorry, I just naturally just stood in the middle of the two.
Sorry.
So ultimately, in terms of the methodologies I've used, a number of workshops and a series of interviews, and from a critical perspective and stuff, what I'm saying here is that I believe if I'd researched this subject using a different research philosophy and a different research approach, I'd have come up with different answers. That might be disputable, but that's kind of where I feel like, and ultimately taking that's relevant in terms of the contribution of theory which I'm making. So ultimately, the whole field of critical digital health is quite small, therefore actually my contribution of knowledge is there. Obviously the contribution of practice in many ways is much more interesting, but that's an entirely different matter. I'll come back to that. It will come out. Ultimately, how this all fits together, ultimately what I'm doing, or what I have been doing, is going through the process of creating theory, context-specific theory, and the process here is putting together a different social theory. The social theory connects with the research philosophy which I'm applying. That is applied to the context of smart community to see if it will improve efficiency in this context. Essentially, that's an overview of what I'm doing. So how I got to the definition of smart community, I have essentially, it's a big part of my literature review, mapped out the evolution of smart community literature over the last 20 years. And the one which is most relevant is one up here. Kinkar here is a piece of research on smart community, which is quite close to the definition which I've come to, but also taking back to much earlier smart community literature. There was a lot of talk about collaboration and the idea of significant change, so I've linked into that. Thinking about the idea of collaboration in the current age, it aligns with the ideas of things like social computing and so on. And then a little diagram on the left-hand side, and you've got some other concepts that link into the idea of social computing and so on. So that's what I mean, and that's what I'm talking about. To give you a bit of an overview there. Links into the idea of smart city, because partly because smart community and smart city are very much aligned conceptually. In a general sense, the idea of smart community is more social, and the idea of smart city is often much more top-down. In more recent literature, they're much more aligned, but there is a bit of a general distinction in terms of that. And ultimately, just in terms of what I've put at the bottom here, it is the idea of smart cities being embedded in a certain idea of urban cybernetics and so on, which is, I'm going to suggest that's a form of thinking about smart cities that ultimately I'm concluding is not likely to result in positive impacts. That will come out talk. So, going through this process, looking at the current system and ultimately how can things change. There's a whole load of different things. It being disconnected and being a lack of interoperability were definite themes that came out quite a lot. It's probably no massive surprise to anybody, and I'm sure the idea of increasing demand and numbers of cancer survivors going up and so on, it's probably no big surprise either. Ideas of lack of prevention, increasing waiting times and so on, and the system being a bit of a maze, probably no huge surprise to you either. Some other things here, the idea of a maze came up again, and something else which I thought was very interesting in terms of some of the comments was the idea of being a lack of ambition. So in terms of asking people about what was good in the current system in some of the interviews, I got comments like, well, we're pretty good at getting people through diagnosis. Services are generally in line with best practice. Was a comment about what was generally good, and I kind of felt with some of the comments that came out was that, well, maybe we should be aiming higher than this. Yeah. So a little story to illustrate some of what's wrong in the current system. If you can make sense of this diagram, I'll talk through it. Ultimately, some bits of current technology being introduced in quite a top-down way. This came out in two of the different interviews, with a lack of consultation, and ultimately, surprise, surprise, top-down intervention, lack of consultation results in the technology not working properly and resistance to change, as you might imagine. The other thing here is, in complete contrast to that, I looked at kind of interviewing people about other technology. So there was some technology called eShift, which is being used by a charity called St. Luke's. Ultimately, the way that they introduce the technology, much more consultation, much more engagement, and much more positive story. Ultimately, what seems to have come out here, and this is just quite representative of quite a lot of the other discussion that took place and so on, is that actually, in terms of getting things right, it's not just about having the right technology. It's actually the way that the technology is introduced is just as important as getting the technology bit right. So to illustrate an example of what is wrong in the current system, I'm not going to talk through all the different strands here. If I just take one example where I've highlighted in red, you start with the idea of incomplete data sets. It links back to the comments I was making a minute ago. Links it to lack of interoperability, poor information systems, which go to expensive treatments, and increased financial pressure and so on. That's part of the problem we've got in the current system. Another part of the current system, another part of the problem is that it's systemic. Ultimately, it's not just that the technology is not done right, it's actually that we are focusing too much on treating people after they're already ill, not focusing enough on prevention, and so ultimately both comments that came out from people in my interviews and workshops, and also in terms of literature, two things very much align to kind of support this kind of idea that actually the way that we're thinking about looking at healthcare isn't right. So what can we do about it? Well, there's a whole load of stuff. The idea of putting the patient in the center, or putting the person in the center, rather, was kind of very important here, and people were very much stressed. It's not just about putting the patient in the center, but it's putting the person in the center, because it should be starting at the beginning of life, cradle to grave as a comment that came up, and carrying on throughout life. So it's even before someone is actually having any treatment, they're right at the whole center of the system. A whole load of other things that came up as the things that could be part of the system: genetic mapping, artificial intelligence, communication, the idea of a health MOT, and so on and so forth. So, however, just doing this stuff isn't necessarily going to make things better. It could make things a lot worse, and there's a massive link here with some of the criticism that's been made of urban design and how that links in terms of smart cities and so on. So it's this idea that having the kind of data-driven healthcare system, a data-driven approach to urban design and stuff has ended up in failure. This idea of being critical of the whole idea of urban cybernetics. So this idea of the parody of Corbusiers' City of Tomorrow is this idea that actually there was a time in the past, particularly in the 1950s and 60s, where we placed a lot of faith in technology and science in order to solve all the problems, and it didn't end perfectly. And to a certain extent, with smarter cities, we are in danger of remaking the same mistakes. Similar ideas came up in terms of my workshops. One thing I will say before I get into this is I specifically asked people in my second workshop to focus on what could go wrong. Focus on the worst possible manifestation of this kind of technology that you can. And so it's unsurprising that some negative comments came up, but we got this idea of corporations nudging people to get ill so that they can make profit and so on. But ultimately, this to a certain extent links into ideas of kind of some of the criticism which has been made of Cambridge Analytica. There was discussion of Cambridge Analytica there. This was prior to all of the recent all the stuff that's come up. And some of the literature talks about the idea of weaponized artificial intelligence. So it's kind of, I think this links back to some of the discussion that's happened earlier this evening about nudging and so on. I think it links to the point you were trying to make, I think. So it's this whole thing. And so in essence, what we're saying here is that some of the critical comments that were made in the workshops is supported by the literature. In essence, is what I'm saying here. Another aspect of control. This image, if you just to explain what this means, this is a picture of a picture of a Panopticon prison inside a mobile phone. Yeah. So there is a whole load of literature that suggests that social media is a self-imposed panopticon. Ultimately, links into that idea. This idea that data is not neutral. The idea of social control, with kind of like it links back to the idea of nudging people into certain behaviour and stuff, is not necessarily positive. So linking this to digital health specifically, I'm going to talk about kind of two different examples. The first thing is IBM Watson. So I don't know how many of you are familiar with IBM Watson? So most of you, yeah. So it's the idea, actually, could be quite positive, analyse a huge amount of data in order to inform inform oncologists in order to make better decision making, millions of records that oncologists don't have time to read all this stuff. However, there is a problem, and the problem is, you're laughing because you probably got. I think you've probably got where I'm going with this, yeah. So the problem here is that actually, even if all of the data was unbiased, even if every clinical trial was free of bias, when you aggregate it together, then it ceases to be unbiased because drug companies have influenced which clinical trials have been done. So ultimately, you got things like the amount of research that's been done into prevention and so forth is a lot less, and even actually the amount of research that's been done into apps and so on compared to drugs is a lot less. So you aggregate it together, you don't end up with an accurate suggestion. So you've got to think. So things links into this, and so on the other side of it is the example of DeepMind. DeepMind was discussed earlier. So there was discussion about Google DeepMind here, and it's the idea that actually that they've got a huge amount of data sets, and that's potentially a problem. Linking this to some of the literature that came up is this idea that DeepMind will keep all of the algorithms, and also the idea that DeepMind had no expertise in healthcare before they started their relationship with the Royal Free. Now, ultimately, that last part suggests to me that it's like, well, actually, if they had no expertise in healthcare before they started the work with the Royal Free, it suggests to me that actually their whole base of the way that they're all working is likely to be purely based on analysing data, rather than understanding the messy complexities of what could go wrong. So linking to one of the comments from one of the people here is that you should never cut people out of the picture because of the subjectivity involved. So I'm not suggesting for a second that digital technologies is not useful, but ultimately we've got to be careful about giving complete control to the technology. That links them into the dystopia side of things. Because ultimately, what we could end up with if we just give a whole load of data to senior healthcare professionals and managers, we could end up with a system where we end up with compliant junior staff and compliant patients and stuff, we could end up with something which is more efficient, but not necessarily as the future we want to move into. So moving rapidly into where I went with this in terms of the process of creating theory and moving towards my conclusion, is there's a whole load of different interviews and workshops and linking this with literature and so on, and create themes and stories and brought it all together in order to create theory. I'm not going to talk you through this whole diagram. I'm just kind of showing it there because it's just to illustrate that there was a clear process, but to get to this point. If you look at the diagram at the bottom, you've got I've put down 4 visions. The vision 1 being top-down government-led, the second one being top-down corporate-led, the third one being bottom-up individualistic, and the fourth one being bottom-up collective. Ultimately, my conclusions were that whilst there might be benefits in each of these different visions, the greatest benefit appeared to be very much to have a greater focus on the bottom-up collective side of things. And ultimately, there's a very big difference between the bottom-up collective and the bottom-up individualistic. The bottom-up individualistic being much more about kind of customer choice, with the bottom-up collective side of things being much more about the real level of engagement that exists in terms of the play and in line with some of the comments from the first speaker and so on. And ultimately, this is basically my theory, that ultimately the idea of smart community is only likely to lead to increased efficiency in a way that's positive under very specific conditions. And they are that we have significant culture change, and there's a distinction here between really changing culture and nudging people to different behaviour, and a move towards structure, so that we're looking at focusing much more on the structural factors that include that affect health and well-being, and that will lead to increased efficiency. This is not easy, that there are lots of reasons why this is massively complicated, not least because actually there are plenty of people who've got a vested interest in the system remaining as it is. And I'm just going to skip over these two. They're thinking about having a more patient-centered approach and more joint up will lead to efficiency. If I just talk through here, take the idea of investing time into developing relationships. Trust can be developed. We were talking about how to develop trust earlier. And that may result in patients being more willing to engage in forums. Patients may be feel less in need of counselling. So this was a specific example that came from one of my work interviews. Less demand on services and cost savings. And finally, ultimately, in terms of this, it's what am I doing next is a question I've been asking myself a lot. And ultimately, when I was talking before, I was talking about 18 months ago or so, I was saying it's like, well, actually, one of the reasons I'm doing this, you're not just doing this to create a thesis to sit up on a wall somewhere. I am actually interested in how I might be able to collaborate with other people. There's been discussion at past events about how we might be able to collaborate on funding bids and so on. So ultimately, if you've got ideas that link into this that you might want to work with me on in order to look at trying to have affect real social change, future funding bids and so on, do talk to me. Thank you.
I'm aware that we're going to get done by 9 o'clock and we've got about 8 minutes left. I'm also aware that Jorge, I think, has to leave because your train is going at about 10 past 9.
No, please.
Are you okay?
It's
It's too late. Oh. And I want to do Smart Sheffield News as well quickly before we go. But if anyone's got one or two, maybe 2 questions for Tim before we finish.
Tim, really quick, we can chat about have you got evidence here that we should be dumping nudge theory and looking at whole cultural change?
Yeah.
Great. I face that battle every day.
Yeah.
I've got a quick question for you, Tim. So clearly you would think systemically around this sort of
Absolutely.
stuff, but that's quite a rare mode of thinking in a lot of this, particularly in health, from my observation. I'm not a mental health practitioner, but you seem to get, very narrowly focused thinking. So So how have you found encouraging people to think systemically, and what's worked and what hasn't worked in that?
It wasn't always easy. There was resistance in some of the sessions to this idea. I think there were times where people found it challenging that I wasn't breaking things down into little individual compartments. But ultimately I just stuck with kind of like stressing the important bit. But so linking to that, the idea of boundaries was really important in terms of this whole thing, which is like that ultimately I've been very deliberate in terms of the boundaries that I've taken. I'm not looking at everything, because you can't look at everything, but ultimately I'm deliberately drawing my boundaries in a place that's somewhat different to how some other people may draw boundaries.
Okay. All right.
Thank you.
I have to say, if there's one thing